Hello, everyone, and thank you for joining us at today's conversations. I know that you are, and I am as well, looking forward to a great discussion and some really great information. But before I get started, I just wanted to mention why this particular topic is so important to the Community Health Endowment. We believe that if you look at good data and you have great discussions, you can come up with some really positive direction and solutions to issues that face our community today. We do have some important data that we have to consider. For example, if we look at our population by race in Lancaster County, we know that back in 1990, we had a much smaller population of people of color in our community. But as we have moved to today, about 20% of our population is considered to be racially or ethnically diverse. But let's look a little bit forward and look at 2050. And we'll find that over 1/3 of our population will be considered people of color. That matters to how we provide health care in our community. And as one example, let's look at first trimester care that a woman receives when she first discovers that she's pregnant. What could be more important than to have health care or information that is in a specific language or that takes into consideration certain cultural practices? But we know that if we look at the white population, over 90% of women will receive that first trimester care. And as we look at other races and ethnicities, we see that as far less. And so we need to be able to reach populations, not only in the language, but in the cultural practices that are so important to them. And that's what we're going to be talking about today with this very important panel and this very important. So thank you again for being here and joining us. I'm going to turn this over to CHE's Health Equity Officer, Selena Martinez, who's going to introduce our panelists and lead us through the conversation.
Good afternoon. Buenas tardes. My name is Selena Martinez. I'm CHE's Equity and Diversity Officer. I just want to kick us off first by sharing my story and why this panel and this topic is so important to me. So I grew up in Lincoln. I grew up in poverty. I grew up in a mixed status family. And so that means that some of us were able to access health care because we were on Medicaid, and some of us were uninsured. And so that really gave me the experience of being able to see and go to just different medical providers and see how ill-prepared they might have been for immigrant families like mine. My parents didn't always have a translator. Sometimes we would hear messages like tortillas, frijoles, beans, staples in our cultural diet being labeled as unhealthy and things that we shouldn't be eating. And those experiences then really helped shape my decision to pursue a medical field once I became a first-generation college student. And when I started college, I was navigating this new space, a space that no one in my support system had ever been in. And on top of that, I had to figure out, how do you go to medical school? How do you apply? What does that path look like? And I remember taking a course really early on where they brought in different medical schools and to share their programming, the admissions. And not once did any of those programs ever share how someone with a cultural background like mine, being Latina, being a Spanish speaker, would be of benefit. And in fact, what most of them said was you needed to be in an entry-level medical field profession like a CNA now. So I'm a freshman in college. I had no idea, and the more I heard that, the more I felt like I was behind. And that really was what made me pivot then to move away from the medical field and pursue something different. And to this day, thinking back on it, it hurt. It's sad. But that's my connection to this conversation today, and why I'm just excited to hear what our panelists have to share. So we're joined today by Dr. Hassan Nassim, who's the medical director of Bryan Psychiatry and chair of the Division of Psychiatry at Bryan Health. He's going to share about his commitment to culturally competent care and his recent efforts to offer a statewide resolution on diversifying the healthcare workforce. Then we'll go to Eric Moss, who's the CEO and president of Bryan Medical Center, who will share Bryan's effort to build up a diverse workforce and why that's important. Then we'll briefly hear from Nicole Robinson with CHI. And we just want to really thank CHI for being here and being committed to this panel. Our original speaker wasn't able to make it, but they still decided to show up, and we really appreciate that. And so Nicole will share about CHI's initiatives to diversify the healthcare workforce and why CHI believes that's important. And then we'll turn it over to Naiduth Gatek, who's a nurse as well as a client of Malone Center's maternal health wellness program. And she's going to share her personal story as a Sudanese woman seeking culturally competent care, specifically in prenatal and postpartum care. And she'll also share her perspective of returning to the workforce, in the medical field after having her baby. So to start, I just want to briefly walk us through some local data regarding racial and ethnic diversity in healthcare professions. This is data from UNMC's Health Professions Tracking Services. We just want to give you all a snapshot of the population that we're talking about today. These are some of the health professions that exist here in Lancaster County, and you'll see that there's 2,918 total providers, so that's just shy of 3,000. And one thing to know is that in most cases, we don't have race and ethnicity data because it doesn't meet the confidentiality threshold. So instead, when we break this down into two categories, so physicians and then all the other professions that you saw on that table, what you can see first is the low number of racial diversity that we have. But then we also see we have a lot to learn because those gray columns there are just show us the percentage of providers who didn't respond. When we look at ethnicity, the same thing is true. You'll see again a high percentage of folks who didn't respond to the question, and then only 1% who identify as Hispanic or Latino. So really the story that the data is telling us is, one, we have a lot to learn. How do we want to improve this data collection? But then also just something that we already probably know, that the number of BIPOC providers doesn't really represent the percentage of BIPOC individuals in our community. So with that, let's turn it over to our first panelist, Dr. Naseem.
Thank you so much. It's wonderful to be here and to be part of this really important dialogue. I'd like to begin by emphasizing that I think it's commonly known that historically physicians were taught to treat the symptom, and patients presented with a clinical problem, so the aim was that you proceed with just addressing that particular issue that has brought them into this clinical encounter. That really created a significant barrier to begin with, right from the offset. It was creating a limitation. Fortunately, healthcare has evolved beyond that, in which now, instead of looking at a symptom, we try to look at the entire individual. And we try to emphasize not just what is the contributing elements, what are those elements pertaining to that particular symptom, but also how is this individual being affected, and then who is this individual that we are trying to help. So the result is a much more comprehensive capability of being able to understand the totality of the need, and then also in many instances prevent complications which would have occurred if we just maintain the focus on that one symptom. In that realm, diversity plays a significant role. We have continued to experience challenges in our understanding of different cultures and patients of different backgrounds. And as easy to understand as that concept is, I think it's really important for us to recognize the implications of that. And the result is that that very principle that I was just discussing of looking at the whole individual, well, it's very hard to do if we don't understand what that individual's life is about. So if they are a refugee, what struggles they live with, if they have been ostracized or rejected because of their sexual identity, what challenges have they endured? Of course, if they are a person of color, what kind of discrimination has already been a part of their life, and how has that affected their capacity to engage in treatment? These variables, which seem so fluid and so amorphous that it's hard for us to quantify them, well, collectively, they play a significant role in how healthcare is imparted, how that clinical encounter's quality is. So although we would like to have more providers be a part of our community in Nebraska so that they can be representative of the changing demographics, which are so visible to all of us, but we also would like to take the present into account and educate all of us to more and more a level of awareness about the struggles which various citizens of our community live with based on the very factors related to diversity, related to their identity. And I think that requires serious conversations. It requires us to examine our way of assessment, our own preconceived notions, and then also it compels us to factor in what preconceived reservations a patient might have by the time they approach us. Are they really telling us the entirety of the symptoms, or just the bare minimum because they feel perhaps that they're not entitled to more? Do they hold back because they have been challenged in the past and negated in the past? Do they trust what we are telling them as being truly in their best interest, or are they simply nodding in agreement and ending that clinical encounter, counting their blessing that they at least were able to get in? Do they tell us about what is the situation at home financially? Do they tell us about the rejection that, again, they might be experiencing not just from society but their own family? How they might feel safety-wise just walking down the street, and what kind of trepidation that might create living where we live because of the color of their skin. So these issues have to be brought to the table, and providers and people who support providers need to engage in this dialogue and to be able to start to study it more so we can improve ourselves. And we can go back to that principle of treating the whole individual, because we understand the whole individual. I would like to briefly also just add about some of the work that we have initiated, and this is because of the fantastic support at Bryan Health and the leadership to allow us to move forward with a resolution with the Nebraska Medical Association. The resolution, again, moving us towards a direction of first identifying a task force which can work on this very important topic for us to get the kind of data that we need to see how are different demographics affecting the penetration into those communities by physicians or providers of color, and whether there is a disparity or not. And of course, we know what the reality is to a great extent. So how can we then help educate all of us so we all become equally comfortable broaching the subject we all become capable of being able to embrace the patient as an individual, recognizing that they are coming in with their own hesitancies, their own histories, and the fact that as providers, it's our duty to address all of them. And I think if we can get to that point of evolution, the quality of healthcare would be remarkably improved. It already is, to be honest, compared to many parts of the country. I think the quality of care in Nebraska is comparatively much better. But these issues, again, which are not so easy to quantify, addressing these issues and broaching these subjects and having this dialogue, I think it will lead us to evolve and improve even further. Okay. There.
Thank you, Dr. Naseem. I also just want to invite folks in the audience and on Zoom to please share your questions on the Q&A feature on Zoom. We'll be getting to those after the panel discussion. Next, we'll have Eric Moss, President and CEO of Bryan Medical Center, share to continue our conversation.
Thanks, Selena, and thanks to CHE for the invitation to be a part of this really important topic. I want to extend my appreciation also to Dr. Naseem and the chance to work together closely for the last 6 years. You can clearly see Dr. Naseem's leadership, his thoughtfulness, his care in this space, and not only has he taken the lead in partnership with the Nebraska Medical Association to really advance and put together a group to talk about this within the provider community, but on a personal story, Dr. Naseem and his wife, who is also a family medicine physician here in Lincoln, their interest in serving the refugee population and having really positive conversations with our colleagues at the Good Neighbor Community Center about ways we can advance health equity there with refugee populations that Good Neighbor serves. I wanted to share a little bit about our strategy around health equity and as it relates to the diversity of our workforce at Bryan. I'll first start and just admit to you that we are nowhere where we want to be in this space, and in fact, some of the data I'll share with you really tells the audience that we're not as far as where we'd like to be. But importantly, I think it's I take pride in the fact that we're addressing this topic and have it as a key strategy within our organization. I'll start and share. Bryan Health is coming up on our 100-year anniversary. In fact, kind of coincidentally here in Lincoln, that both Bryan Memorial and Lincoln General Hospital were founded about the same time in 1926. And this quote was actually coming from our 20-year anniversary of Bryan Memorial back in 1946. That has kind of served as a guidepost to us related to this work. It says, to contribute to the long list of sympathetic friends who have undertaken at much sacrifice and work a perpetual service to the distressed and unfortunate in this unceasing profession to serve humanity. And I think as a healthcare provider organization and filled with colleagues at this table even, that most of us get into healthcare because we want to help people. And I know that's fundamental to the mission of Community Health Endowment as well, and that's guiding our work in this space. At Bryan, we have a strategic plan like most organizations, and I would tell you that our work around diversity, equity, inclusion is really founded in what we're calling health equity. This notion of we want every individual in our community the chance to live a healthy life, and that is every individual, not just people of majority status. And so calling out our 5 driving strategies under our strategic plan, one of our driving strategies is specific to improving community health. Diving deeper in that driving strategy then is specific work around our diverse workforce. So we break our diverse workforce down into our provider population, our leadership, and our overall workforce. And I'll share with you some statistics here to describe kind of where we're at and make some comments about some of the initiatives we're taking. Related to this strategic plan and our work, first is making sure that we're collecting the right data. Selena shared the data that we have around our workforce is largely incomplete because we don't require it in any space. In fact, at the state level, the state licensure board is not collecting this data, and this is something that we believe would be helpful. We understand the initial reservations about privacy and potential discrimination, but we believe that collecting data at the state level could be helpful. In the absence of that, we're relying on self-reported information, and so we understand how incomplete that is. But capturing that real data, race, ethnicity, and language data on our overall workforce is an important first component. Even with Lori's start of her comments at the beginning of the panel, it was understanding data helps inform strategy. The second aspect of our community health or health equity work is around understanding key healthcare initiatives and stratifying that amongst our patient population to determine if there are disparities in care. Specifically looking at cancer screening, hypertension, and behavioral health screening. Fortunately, what we found on one hand is when we look at our breast cancer screening rates segmented by the population, what we find is breast cancer screening actually does not show a disparity in people of underrepresented minorities not getting screening, so that they're within a percentage point of a white majority in terms of screening rates. However, when we look at colorectal cancer screening, we find a different story, and that we do see disparities, particularly among our African American population in the community, of less screening rates for colorectal cancer screening than the white majority. And this is, again, understanding the data so we can take action to make improvements. The third, and something I'll share a little bit more on, is the intentional focus on workforce diversity amongst our Bryan College students, amongst our provider community, and within our leadership, specifically at Bryan Health. And then finally, around education and affinity groups, what are we doing to create conversations and be a part of conversations, frankly, like these, to help advance this work in our community. So let me focus for a couple of minutes on the provider diversity, and this ties well to Selena's comments earlier with the UNMC Health Professions Tracking. First and foremost this is self-reported data within the Bryan Health medical staff. So the numbers you see that may not be entirely jive with Selena's comments earlier. Selena's comments were Lancaster County providers in total. This is Bryan Health medical staff members. And you can see really across the board that our numbers within Bryan Health suggest our providers are not reflective of the community we serve. To add a comment to what Dr. Naseem mentioned a minute ago, what we believe is that for patients to have more positive health outcomes and trust with providers, we find and research suggests that when those providers look like and have shared experiences to those patients, health outcomes are better. And so that has prompted us to really focus more intentionally on recruiting a provider workforce that's reflective of our broader community. I'll make one more comment here. Even in the Asian population that looks to be somewhat representative, what we find is a provider of a background of the Indian subcontinent, like Dr. Naseem is not the same as a provider of Southeast Asian descent from Vietnam or Thailand. And so being able to be reflective of our community suggests that we need to even be more specific. And so one of the things I'm really excited about, even just news of this week, is we were able to sign a new family medicine physician, primary care physician, who is from Lincoln, grew up in Lincoln, is Vietnamese by background, Vietnamese speaker, who's completing her family medicine residency and will continue to practice in Lincoln post her training. And she's not only will that enhance primary care access in Lincoln, but she's also specifically excited to take care of our neighbors in the Southeast Asian community. Let me talk a little bit about leadership, and this is an area where I would admit to you that we're not as far as we'd like to be, and kind of frankly embarrassingly behind other organizations that have had leadership that's more reflective of the community. Again, having people of different backgrounds around the table making decisions, influencing our workforce, allows us to have better, more culturally competent care and better health outcomes overall. And you can see the overwhelming majority population being white of our leadership team. We have made some strides, but we have a long ways to go from our leadership space. Leadership includes manager, director, and vice president level positions here. And as I'm sure our colleagues from CHI can attest, that this is hard work. This is kind of what I'd call brick by brick, a level of relationships. There's one level of relationship or conversation leads to a next. Something that I've done intentionally is looked at our workforce of underrepresented minorities and seeing how I can personally mentor with individual conversations, people of underrepresented minorities, to lead them into leadership positions and kind of grow our own within our workforce community at Bryan. This slide shows our overall workforce, and again, it's I would tell you a mixed story. Our overall workforce, while not entirely representative of the community, also has kind of subcomponents through it. So the diversity of our workforce is actually very strong in our frontline entry-level professions such as certified nursing assistants, phlebotomy, environmental services. However, it's not as reflected in our other clinical care areas like nursing, respiratory therapy, laboratory, and others, where, again, having people of underrepresented minorities participate in that care goes back to what Dr. Naseem says, that trust is higher. People who care for you, that have shared experiences, generally the outcomes are better. And this is something, again, we acknowledge and are working to try and address. I'll make one more comment about our data and then just share some summary comments. The next is around our student enrollment with our Bryan College of Health Sciences. Some of you in the community may not be as familiar with our Bryan College of Health Sciences, but it's an undergraduate and graduate school with about 750 students, largely nursing students, but in other professions as well, such as nurse anesthesia, sonography, biomedical sciences, amongst others. And you can see, based on intentional efforts from our Bryan College leadership to increase the diversity of our enrollment in the Bryan College, went from 9% of underrepresented minorities enrolled in the college back in 2014, not quite 10 years ago, to now almost 25%, almost a quarter of students at the Bryan College of Health Sciences are now represented as a member of an underrepresented minority. Thinking that this is the pipeline that we're going to build in order to change our workforce, the workforce demographics, as well as our provider demographics, as many of these students not only go into nursing or biomedical sciences, they would then become nurse practitioners, physician assistants, or even pursue medical school. So my last slide and just some summary comments. I won't go through all of them, but I will point out a couple that we're really proud of and believe that will make an impact. I mentioned the leadership, the diversity of our leadership not being representative, but I will say we've made great improvements in the leadership or diversity of our board. So our governance is now much more reflective of our community as a whole. And this is where the top of the organization lives, at the governance level. And so having different voices at the board table is really helping us advance this conversation throughout the organization. Another is through our electronic medical record. We use Epic electronic health record, just as CHI does, which is a huge advantage to Lincolnites. But that as part of that health record, we implemented processes to identify or to capture gender identity and sexual orientation. And we did that about 2 years ago to capture 6,000 employees to convince, if you will, 6,000 employees to be attuned to capturing this data for our neighbors that we're serving took a fair amount of effort, as you can imagine, but really proud of the opportunity to provide care in a better way to people with different sexual orientation or gender identity sensitive care. Finally, I'll comment on our work with Lincoln Northwest High School, and some of you know as that new high school came live this academic year, that's a medical part of that high school as a medical focused program, and Bryan College of Health Sciences is really proud to be the academic partner for that Lincoln Northwest High School's medical focused program. So we're involved in training high school students to orient them into healthcare professions, thinking that is a pipeline that we can build. So it's not just, it's beyond really the college students that we're now working with. It's now going deeper into high school, which we believe we're able to build that pipeline better. I'll wrap up those comments there, Selena. Thank you.
Thanks, Eric. Just a quick note that the PowerPoint that you have seen today and a recording of this conversation is going to be available on CHE's website later. And then a friendly reminder that as you're listening, if you have questions, please use the Q&A feature on Zoom to share those with us. And now we're going to turn it over to Nicole Robinson to share.
Thank you, Selena. I'm Nicole Robinson, and I am the Midwest Division's HR Business Partner for Diversity and Inclusion for CHI Health. As Lori had mentioned when she opened, with that data, looking at the minority populations in Lancaster County and Nebraska overall, we realized that those populations are growing and they're going to continue to grow. So CHI Health, along with several other organizations, has realized the importance of developing a health equity strategy to ensure that we can serve those communities. And so our health equity strategy, very similar to Bryan Health, does include those 3 pillars that focuses on our providers, our patients, and then also our employees. And that employee pillar really hones in on how we can diversify our workforce. So what we've done is partnered, with our talent acquisition department to ensure that we're slating for candidate positions for a VP and above. The expectation is that if we see more diversity and inclusive leaders at the higher level, we hope that will have more of an impact on hiring practices throughout positions throughout all levels of the organization. In addition to that, we have we make sure that the EEOC information for all candidates is hidden throughout the recruiting process for candidates that are applying for positions below the VP level, to just ensure that we avoid any bias impacting that recruiting process. And then beyond hiring the diverse employees, we need to make sure that we're setting them up for success. Like Selena mentioned, when she looked into becoming, going into the healthcare industry, she felt like she was a little behind. And that is the experience that many of our minority employees, realize that, oh my gosh, I feel like I should have, I should be more caught up. So we want to make sure that we're providing the resources and support for those employees. And that includes, we partnered with Willie Barney and the Empowerment Network in Omaha to provide Redefine the Game program for our mid-level employees, help them learn what it takes to reach that management level, provide those connections and networks. And then also for more of our entry-level employees, we've partnered with Omaha Bridges Out of Poverty to provide a 10-week workshop, which is getting ahead in the workplace. Because we realize that although we've hired these employees, we still have so many people that are working but living in poverty, and that can deter them. If they feel like they're behind, if they feel like they're not getting the resources that they need, they're going to leave the industry and look somewhere else. And so that getting ahead in the workplace workshop focuses on teaching them things like creating financial stability. Changing their thought process so they're more reactive versus proactive, and just providing a various amount of resources, which includes individual coaching once they reach the end of that program. And so we're piloting that right now at our flagship hospital in Omaha, Nebraska. But the hope is that we see a high enough success rate that we can offer that throughout all of our locations in Omaha, Lincoln, and Western Nebraska. And then we've also partnered with other community organizations like Fulton Homes Education Center. They are a Black-owned organization that provides training for different aspects in healthcare, like pharmacy technicians, CNA, CMA, phlebotomy. And so we've partnered with them because they have, being a Black-owned organization and being founded by two women of color that were in the healthcare industry, they really focus on those underserved communities. And because of that, they have an 80% minority enrollment rate. And so that's a huge talent pool of diverse candidates that we can work with. We're offering them the training that they might not have known existed or might not have had access to otherwise, and giving them that opportunity. And then once they complete that training, we're right there offering them positions within CHI as CNAs, phlebotomists, med techs. And then once they're hired with us, again, going through those programs, getting ahead in the workplace, redefine the game, participating in our employee resource groups, our mentorship programs, so that they can continue to grow and develop with the organization. And it's there's a quote from Dr. Kedar Mate. He is the CEO of the Institute for Healthcare Improvement. And he said that there is no quality healthcare without equity. And that's really why it's important for CHI and everyone here to diversify the workforce within healthcare, because in order for us to really serve those underserved communities, effectively care for our patients, we have to have employees at the table that can relate. We want our employees to be able to feel comfortable. That data is very important to making those informed healthcare decisions. And recently, looking at the data for the real data and SOGI data that we collect from our patients, there's still such a large number of undetermined or unknown. So a lot of our patients, we realize, are not forthcoming with that race and religion and ethnicity information. And so we want to have employees that represent the communities and patients that we're serving, so they feel comfortable and can better explain to the patients why this data is so important. I know prior to coming into healthcare myself, I would have been more hesitant to provide that data. We have so many minority patients that are skeptical for several reasons because of experiences that they had. They feel providing this information may impact the healthcare that they have. So we really would just want to do a better job of educating our patients about why it's important for them to provide that information, so we can move forward with ensuring that we're creating that equitable healthcare experience.
Thank you, Nicole.
Thank you.
We're going to move it over to our final panelist, Naiduth Gatkek, who's going to share her story and experience as a patient and as a medical professional. Naiduth.
Thank you. There was so much joy in learning that I would become a mother, and that not many people go through this journey in life, this duty of becoming a mother. But there was also fear, and that fear was of the uncertainty. We're in a global crisis, and now I'm sick.
I couldn't be seen for 2 weeks, and in those 2 weeks I was met with deciding who my provider would be, and it was a male or a female provider. Ultimately, I went with that female provider, and in those 2 weeks of isolation, I was calling my doctor's office, talking to the nurses, but wanting to speak to my doctor. And I would call and call and call, and I would only get responses back from the nurses and not my doctor. 2 weeks later, I finally think I'm going to meet my OB, but I met with her nurses, and that was disappointing because I consistently called. There was so much uncertainty. I was pregnant, I was isolated, and I worked in the healthcare where our facilities were flooded with patients that were sick. and I was now one of those patients. And that was hard. So with my first appointment, I did not meet my OB, but with my second and third, I finally met my OB. And there was relief in that, but instantly I knew that my OB did not meet me at that patient-provider level. At my appointments, she talked at me. She gave me misinformation. And her staff talked about me. They spoke about my occupation. So my provider also joined in on that. They spoke about my occupation. They spoke about me, but they never spoke to me. And oftentimes, I found myself alone in my provider's office. And my provider would only come in, she'd be in for 2 minutes, and then she was gone. And oftentimes, I found myself seeing myself out, and those exit doors seemed longer and further at the end of every visit. At the end of every visit, I didn't feel heard. I didn't receive the interaction that I expected from my providers and her team. And so it's finally my 5-month ultrasound, and we're going to find out what we're having. So Adam accompanies me, and my provider comes in at the end of the ultrasound, and she sits down and she says, "So you're having a boy." She doesn't congratulate us, and she doesn't acknowledge Adam. He was in and out in less than 2 minutes. And then Adam looked over to me and said, "I do not want her delivering our baby. I do not want her a part of our journey." And I needed that reassurance because at 6 weeks and 5 months into my pregnancy, my provider did not establish that relationship that I needed. I did not feel comfortable. Her staff talked about me, and I oftentimes sat alone in those exam rooms. So at 5 months, I'm pregnant, and I fire my OB. I fired her in my head, though. It was a collective decision that Adam and I came together and not continuing our journey with this OB. So for 4 weeks, I'm without a provider, I'm pregnant, and finally, I find my OB. My 2 non-negotiables was a woman, person of, and I got those. And it felt so good. At my very first OB appointment with my new provider, she was actually at that appointment, and she asked me a lot of intake questions that my previous provider and her team did not. I had a very significant female reproductive history that started at the age of 14, and she was able to answer those questions that were never asked. And that also triggered me in asking my mother more about her reproductive health and learning about that. And for 6 months, I did not have those answers. I was not asked those answers. And finally, I had a female person of color who was able to talk to me, about my blood type, and that if you're an O positive, that you can expect your child to be born with a higher bilirubin. And so when I delivered, our son did have jaundice, but because she was able to educate me on that right away, there was no fear or uncertainty, but a relief in knowing that I had already received. But there was a lot of guilt in my new provider that I had, because I was overwhelming a system that was poor to represent people of lower income. But because I wasn't receiving the care that I deserved within my network, I went outside of my network to receive the care that I deserved, the treatment that I deserved. And I needed that more than the guilt of overwhelming a system that was already with patients. It was finally my induction day, and I did have a high-risk pregnancy because of the stress that I induced and other combinations of things. And I had a amazing labor and delivery. I had my team. I had Adam and my older sister. I had my doula. And then I was wheeled up to my postpartum floor. I met two of my nurses. One hardly said anything, and the other one was an orienting nurse on the floor. The nurse that hardly spoke touched Ezra on the forehead, and instantly I was frightened because in my Sudanese culture, you don't touch a baby because, especially if they're new. And then it was shift change, and they were doing bedside report, and the oncoming nurse just kept referring to me as she. She needs to get up. Why hasn't she gotten up? She needs to void. So finally I got up, but it was 12 hours after I had given birth. And a couple more hours in bed. I wasn't told to get up, move, use the bathroom. I wasn't asked about my pain. My birthing plan was to have no medication at all. I did not have an epidural. I labored for those 12 hours, and I pushed for one. I delivered a healthy baby boy, but I didn't have my pain. And so I laid in bed for almost a full day in pain, not knowing that I should get up. And finally, when I got up, I just tell you is you should not have large gall-sized blood clots. And sure enough, I had large-sized. Frightened. She called my charge nurse, or my nurse, and my nurse didn't come in for another hour and a half. At that point, it was shift change, and the oncoming nurse was there. So for 12 hours, the nurse did not stop she did not to get up to move. I did not go back to work for an additional 4 weeks, and it required therapy. And the treatment that I received from my original OB, her nursing staff, and what I experienced on the postpartum floor created wounds. And those wounds had stunted my healing. And when you're a patient and when you're wounded, your healing is delayed. You delay wanting to speak to other providers. You delay your care. It creates gaps in your care. At 5 months, I should have never gone 4 weeks without an OB. I should have never gone without an OB. I should have never been talked about, but never talked to. And the misinformation that I received could have been damaging. But because I had Malone Maternal Wellness, they came into my pregnancy at my final trimester. I was 35 weeks pregnant. I was able to immediately get signed up in a birthing course. I was able to interview my potential doulas. I eventually went with Ziara, and I was also assigned a lactician. And I had a postpartum doula and lactician for 6 weeks. But because of the relationship that I formed and the moms that were within the group, it has now continued 14 months postpartum. The Malone Maternal Wellness doesn't just provide to low-income minority mothers, but it seeks out women of all women who identify as diversity, but also women who are from all income tax brackets, not low income. And I was an educated mom working in the healthcare field, and I was mistreated, and those wounds were deep, you know. But Malone Maternal Wellness, the support that I received at home, created the healing that I needed. And because of Malone Maternal Wellness, they provided courses or scholarships through Southeast to where you can take educator courses. And because of Malone, I'm now a certified breastfeeding educator nurse as well. And I'm also a part of their milk care committee because of that. And because I have that community, and because I had my primary and my OB that was a person of color, it created the wound healing that I needed, because she was able to see that I was wounded from my previous OB. She was able to sit down and ask the necessary questions. She was able to follow up. She called me back. And those are what created the healing that I need. My name is Naidu, and I'm healing.
Your powerful story with. We're going to go ahead and move into questions from the audience.
This first question is, how is Brian and CHI supporting the provider pipeline for people of various backgrounds? The second question reads, how do we ensure there are diverse providers to recruit?
Okay. Two things I think of, Selena, in response to that question. First is what we're doing currently with our, if I can say, limited numbers of providers in the underrepresented minority community. One is just having intentional conversations with them. First and foremost about is Lincoln and is Brian a place where you feel supported in your practice, and have been really fortunate to have some of those conversations over the course of the last year with several of our providers, both nurse practitioners, physician assistants, and physicians, learning about their story, learning about where they feel unsupported, and really finding that so many of them are desirous of helping us in this way. And so in the notion of recruitment, actually helping or asking them to help us because they've offered that. And so as an example, meeting with two of our physicians, one a cardiologist and one is a surgeon, who are both African American and both going to historically black colleges and universities. And so leveraging their connections with their education programs to help us build this pipeline of people who may be interested even in coming to do shadowing through those colleges. So that's one example that on one hand, I think working with the diverse community we have here, what we find from a recruitment standpoint is it's a lot easier to recruit to Lincoln when somebody already has a connection to Lincoln or to Nebraska. Finding people who want to move to Lincoln. Lincoln doesn't often show up on people's radars, unfortunately, if you don't already have a connection to Nebraska. So part of it is working with the population we have today, like through the Lincoln Northwest High School program, but then leveraging also the relationships that our current providers have across the country. Nicole, do you want to?
Just a quick aside, we just visited yesterday Northwest High School, and to see their new Brian Health Sciences focus program, and met the students. And that was just such a thrill to see so many young people wanting to go into this field, such a diverse group as well. So that was really firsthand. I saw it just yesterday.
Thank you. So I am actually going to let Jennifer answer this question. Not only was she our HR business partner for diversity and inclusion prior to me having the role, she is now our HR director for our physician enterprise and clinics. So she works quite a bit with our providers and finance.
Thank you. Hi, I'm Jennifer Jones, HR director, as Nicole mentioned, for our physician enterprise. So similar to what Eric did state, Nebraska is not where people seek to come, but we do the same thing. So we are recruiting I partner with our physician recruitment team. So we are recruiting from the historically Black colleges. Outside of that, we're trying to build programs that we can reach out to those that have come that are diverse or what have you, have diverse backgrounds, and how do we tap into that talent that you have connections with? How do we help build that community, and how do we identify that community and in Omaha and Lincoln, Nebraska for them as well? So we want to build this, again, community for everyone. And we also have on our provider recruitment team, we have someone that is specifically about provider retention. So they meet with them and talk to them about what is it that you want or what did you need? How can we help you throughout your stay in Lincoln or in Omaha as well, or Grand Island and in West Nebraska too, Western Nebraska as well. So we're really tapping into that talent pool that we already have to pull in more diverse talent and support them as well.
Great, thank you. The next question is for Dr. Naseem. How can people get involved in the Nebraska Medical Association Task Force?
I appreciate the question. Nebraska Medical Association has created its own series of steps in order to pursue the actual final membership of this task force. They would like to be as inclusive as possible. So it seems like the first few steps would be asking various physicians and providers to express interest, and then based on that, to move towards selection of a group which is diverse enough and then representative. At Bryan Health, we have created a small workforce of our own, task force, if I can call it that. The aim of this group of physicians is to start applying energy within our healthcare system in order to be able to create the changes that we would like to see. And the reason for this fluency at Bryan Health is because of our familiarity with our culture, the challenges which exist, but also the expediency which our history of working together allows. However, this is something which we have taken upon ourselves to pursue because of the interest, the passion, and the needs involved. I would like to emphasize that it doesn't really require a task force in order for any group to be able to move forward. I hope that these examples encourage other organizations to do the same, but from a physician or provider level, a small group can equally achieve what is needed. And what we are all pointing towards is the need for more awareness and more recognition of what people of color, but also people coming from other diverse cultures and background are experiencing. So local conversations, I think, are very powerful. I think they create the kind of impact which is quick, easy to implement, and hopefully easy to assess whether our approach is working or not, because we are implementing it in our own clinics, and then we can tell how the response is in our. It can also foster a dialogue which some people might not have had before. And wouldn't it be great for us to have young professionals be a part of a discussion as they're joining the medical community and becoming very quickly aware and familiar with this way of problem solving? I think it also allows, if small groups are working at independent level, to connect with each other, because the hope would be that these series of discussions and these conversations attract the attention of other people, and folks who are asking these questions start asking these questions internally. And if it can become a catalyst towards more evolved, more detailed, more honest discussions, well, I think we would have achieved at least a small milestone just in that. But it doesn't take away from the fact of a formal approach, of a statewide, application of effort, and we are appreciative of the effort that NMA is willing to move forward with. But as we are doing in our own organization and in our own small work group, well, I would encourage everybody else to do the same.
That's great. Thank you, Dr. Naseem. This question is for the entire group, so just be thinking. Do you include individuals with lived experience on your board? Does CHI want to start since started with Brian last time?
Yes, we do include individuals from different backgrounds and those various lived experiences on our boards. We have our primary fiduciary board for CHI Health, and we make sure that we have representation from all different areas in Nebraska. And then we also have our hospital community boards for each of our facilities, and those boards are made up of individuals that are very active in the communities that they serve. So we have that representation. And just recently, I know this doesn't apply to Nebraska, Omaha, or Lincoln, but our Midwest division also consists of Minnesota and North Dakota. And I really loved the fact that one of our adult care facilities in North Dakota, it's a home for adults with disabilities, and they actually have someone that was there receiving care as a member of the board, because it's always important to have someone with those lived experiences to have a voice at the table. Otherwise, how can you really make an impactful decision?
Just make a comment actually about CHI's national leadership in this space. And when you read the journals and in the healthcare literature, healthcare leadership, CHI and their parent Common Spirit Health have long been leaders in advancing leadership investment and governance investment amongst underrepresented minorities, specifically amongst African American leadership. And they've long been a model to look to throughout my career as well. For Brian, as I mentioned during my comments, that yes, we have made intentional strides on adding board members of underrepresented minorities here in Lincoln, and have increased specifically the amount of board members from the Asian community, from the Spanish-speaking community, and from the African American community just in the last 2 years to our board to make it more reflective of our overall Lincoln community.
Great, thank you. These next two questions are for Eric. The first one reads, with all the diversity initiatives at Bryan, what does the timeline look like for bringing in a chief diversity? And then the second question is, does the percentage of employee hires reflect the same increase shown for the College of Health Science?
Yes, this is an interesting question that we debate a fair amount in our organization about a specific leadership position for this work. And some of you know Dr. Helen Fagan in our community, and really a pioneering leader in this space. Actually was a former member of the Bryan leadership team, and a lot of experience still resonates from Dr. Fagan's work at Bryan. But what we've really decided is that this is not the work of one singular individual, that this is the work of all of us, and that in the context of health equity, that this is work all of us own. And so the way we've approached it is really by putting intentional structure around committees and work groups within our teams. I mentioned that from our strategic plan, this is called out, and then the tactics under that strategic plan. Each of those tactics has an individual leader and has a work group. So as an example, I'm leading the provider workforce tactic that meets every other week with progress updates that I believe we're accomplishing the same level of momentum as we would with an individual leader assigned to this space. The second question, does the percentage of employee hires reflect the same increase shown for the College of Health Sciences? The answer is no, that what we've seen in terms of the diversity of our student enrollment of the Bryan College is not does not match the speed in which we've hired underrepresented minorities into our overall workforce. However, the college enrollment does lead into a pipeline of our Bryan workforce. As a statistic, historically, 50% of our Bryan College of Health Sciences nursing graduates are hired at Bryan. So 50%. In fact, just this last class, the December graduating class, 64% of the Bryan College nursing graduates were hired at Bryan. Well, if 25% of that class is now made up of an underrepresented minority, that means that we're infusing our workforce with more underrepresented minorities based on that pipeline.
Thank you, Eric. The next question is for Naidu. What do you wish providers knew about being a minority woman getting healthcare while pregnant?
The big thing is our expectations. Our expectations are low because of the history behind it. My grandmother, she has a son who's a doctor, daughter who's a nurse, and 3 granddaughters who are nurses. And even here in the United States, there's a distrust that she has with providers because they don't look like her. And if we seen more providers that look like us, or with our initial appointments, if the providers or the nurses ask, do you have a primary PCP? Is there any gaps in your care? What needs do you need culturally, if any? And those create a relationship. They establish trust. But there is a historical distrust that we minorities have when it comes to providers. And that distrust is not just only from patients, but also from minorities who work in the healthcare. And if we bridge that gap, then we'd be able to have a better relationship. And so I think bridging that gap is important. Providers could adopt wound care. Wound care is identifying that that patient is wounded and there's no trust. And so when you're wounded, that provider needs to provide that care, and that care that they provide, you'd have to meet there where you're wounded in order to facilitate a relationship or to create healing. So if we adapt wound care to create healing, to create
I could just comment, just hearing Naidu's story and her response just resonates with me the importance of 2 aspects of this work. One is the delivery of culturally competent care across all of our providers, not just across all of our caregivers, I should say, not just caregivers of underrepresented minorities. So delivery of culturally and education of culturally competent care, but also then having providers who also reflect our community that you were talking about, the trust that you have of seeking out a provider, a woman of color. And as you know, the options are so limited in our community. We need to be more aggressive and intentional about adding more providers of color to our community so that more people can out that level.
The next question is, there are so many gatekeepers when a person goes into medicine. For example, university acceptance, medical school acceptance, residency, fellowship. And the question is, how can we help ensure that implicit bias is not unintentionally impacting the pipeline at each level?
This question really resonates with me because this is a lived experience. And I very clearly remember the fear and the trepidation I experienced going in for interviews, looking around that room and at other candidates and wondering, what small chance I would have of getting into a residency or fellowship. Um, so, so I totally understand. I think implicit bias is one of those very difficult to identify and address issues. I wish it were more like a rock that you can contend with, but it's more like sand that slips through your fingers, and you can feel it, but you can't seem to control it or to be able to challenge it or contain it. Um, so, in my mind, I, I think the one of the at least steps that has to be taken is greater advocacy, and it is, I think, dependent on all of us. I think we are all equally responsible for generating a level of safety and confidence so that visible minorities or people who have been persecuted or rejected for so many other reasons have the confidence in being able to move forward. And by noticing a clear change, a visible change that all of us together can cultivate, hopefully infuses some level of honesty that is so transparent and so visible to a potential candidate that they are not hesitant and they're not fearful of being able to apply and confident that they'll move forward based on merit alone. So I hope that that's able to provide some sense of direction, but I know it's a very difficult challenge. I hope that this is sort of one of the first few steps which leads to a change.
This question is for everyone. How can those who are not in leadership positions help support diversity within healthcare organizations in the community?
Um, the way that those that are not necessarily in leadership positions help, drive that conversation and really encourage the importance of diversity, is just, take that risk, be willing to speak up. And then it's also the responsibility of the organizations to empower those employees. So at CHI Health, even though, when we're having those strategic meetings and we're having those conversations with our executive leadership, it's not only executive leadership in the room. I actually was just on a call related to our maternal health care initiatives, what we're doing to address the disparities in Black maternal health, with our division director, our supervisors, our managers. But in that room, there also were RNs. There was, CNA, med techs of color that could, really speak to those experiences because they have lived them or they have loved ones that have lived them. So, be as that employee, be willing to take that risk and speak up. And if you are in a leadership position in the organization, give those employees a seat at the table. You don't have to be a leader in order to have a seat at the table.
I just want to add to that too for those employees. Each company usually does the employee experience surveys, satisfaction surveys. That's a way that you can speak up about what's going on in your organization and what you need to see in your organization. If you have ERGs, employee resource groups, join those groups or identify what the need of those groups are and make sure you're letting leadership know as well. That's one way for you to have a voice within your organization as well.
I just want to of it. I think it's important for leaders to not just look at us, but see. Oftentimes, leaders who don't look like us don't see. And when you don't see us, it prevents advance. It creates those glass where you cannot advance. So if leaders looked and saw us more, I think it would create more diversity in the healthcare, in boardrooms, with your staff, which is important. So I've been with Malone for over a year now,
and it's been a wonderful experience. They came in at my last trimester, and I've created friendships with these moms. I've been able to meet weekly. We meet weekly. If we don't, we will meet through Zoom. And it's created long-lasting friendships. We have a tech group where we're able to discuss our fears, our joys, and our uncertainty. And the Malone Maternal Wellness not only provides to just mothers, they help mothers and their children. And we also have, they provide programs where if you're breastfeeding, you'll be met with a lactation throughout your breastfeeding journey. And because of the Malone, I'm able to still breastfeed my son at 14 months post. They've helped me with my decrease in supply, with my stress, supplements for reaching out to my providers about supplements that are important that I should be taking. And that overall has helped me in my journey as a mom. It's created a foundation in me wanting to have outreach in our community. And because I am a certified breastfeeding educator, I'm able to reach women of color. Because I'm part of the milk, we not reach out to minorities, but to moms in Lincoln and in our surroundings. If they do have a decreased supply, we're able to provide milk through milk sharing, where our donors go through lab through questions. We then provide the milk to.
So the last two questions. So the first one is, Nicole mentioned a workforce organization earlier. What was that called? It focuses on onboarding training underrepresented or minority healthcare.
So I did mention two organizations. I'm not sure which one you're particularly referring to. So there is Omaha Bridges Out of Poverty that offers that Getting Ahead in the Workplace workshop that focuses on employees that have, particularly come from underserved communities or may still be experiencing poverty and providing additional resources. And then there's also Fulton Homes Education Center. And that is the training organization that is founded and co-owned by two African American women that were in healthcare, and they, also focus on training those from those underserved communities.
I would also mention that we do have Bridges Out of Poverty here in Lincoln too. You can look at the Lincoln Food Bank of Lincoln, and you'd be able to find out that information here as well in Lincoln.
Thank you. We'll end on this question. How do we get this type of conversation incorporated into the curriculum at the Bryan College of Health Sciences?
So I think if there is one thing that we are learning from this experience, it is the need for advocacy. It is the need for people to stand up and speak up about things which are important and of which time has clearly come. It is my humble advice to the students at the college to express that to their education leadership. And hopefully they will find a very resonant audience. But should that not come to pass, it does not stop students from collecting together and having discussions together. And I'm not talking about in cafeteria, it can be organized. It can be organized by students, to be addressed by students. So it doesn't have to have some kind of an incubation period while the leadership is trying to insert this into a curriculum. It can just begin as all things begin in a sort of rudimentary form and hopefully grow from there. But I wish the person who wrote that question, best of luck. I have had some dealings with the college, and I know that they would be very keen. I'm sure of that.
Before I address the Bryan College, I'll just offer a couple, I think, positive notes of other education programs. One is I had a conversation with one of the associate deans at the University of Nebraska Medical Center, the School of Medicine, so training physicians at UNMC in Omaha. And we were talking about this and really trying to build a connection so we could build a pipeline for attracting people, students, either medical students or residents, to come do shadowing opportunities here in Lincoln. And what was really encouraging was they were already incorporating this type of both conversation, implicit bias training, culturally competent care into the curriculum for medicine training at UNMC. Another is I have the opportunity to work very closely with a family medicine residency here in Lincoln. The Lincoln Family Medicine Residency Program, part of Lincoln Medical Education Partnership. This is a family medicine residency here in Lincoln that's jointly sponsored actually by Bryan and by CHI. And as part of the board of that organization, we've had meaningful conversations about ensuring that the family medicine residents here in Lincoln are receiving both cultural competency training, implicit bias training, and using it as a platform to recruit students of underrepresented minorities to come do family medicine residency right here in Lincoln. But as it pertains to the Bryan College, this is something that I will personally be taken back to work with our president of our Bryan College and our provost to learn about what we are doing and ensure that to see if there are opportunities for advanced learning in this area.
Well, thank you, everyone. Thank you to the panel for sharing their time and their vulnerability and answering the questions. Thank you to the audience as well for sticking around for this last hour and a half, asking those thoughtful questions. Really, the goal of this conversation was to highlight the intersection of health and culture, as well as provide you with data and information about diversity in our current healthcare workforce and initiatives to increase it. The recording of this conversation will be available later on CH's website, as well as PowerPoint answers to any questions that we didn't do today. If you'd like to join us for the next community conversation, please sign up for our future emails. I believe there will be a link in the chat that you can click on and add your email to. Today's event was sponsored by the Community Health Endowment, who seeks to make Lincoln the healthiest city in the nation. We are investing in health-related projects and programs and convening forums such as this one on health-related topics. Thanks for joining us. Keep an eye out for the next community conversation. I'm Selena Martinez. Thank you.